Yeah, and thank you, Melissa and Rusty, for your work in accomplishing the support for George's trip. So it's a real pleasure to introduce George Richardson to you all. I've known George for 3 decades now, quite a while, and he's really been instrumental for my career in training. So George is from Iowa. He's currently the professor and chair at University of Iowa of Neurology, and he's the Roy Carver Chair of Neuroscience there. He did his undergraduate education in aeronautical engineering, or aerospace engineering at Iowa State, before he went to Iowa in the MD Ph.D. program. As accomplished as George has been, and I think his career is a little bit of a disappointment to him because he initially wanted to be an astronaut. So he didn't do that, but he's done a great deal of other things. After he finished his PhD with Peter Getting at Iowa, where he did a lot of important work on the generation of rhythmic respiratory activity in the brainstem and the role of neuromodulators in generating that rhythmic respiratory activity, he went to Yale for his neurology residency and really stayed there for most of his career until he moved to Iowa. He became a full professor of neurology and cellular and molecular physiology at Yale. And, you know, when I was thinking about George's career, there's a comment from Alan Hodgkin of squid giant axon fame. He described a criticism that he received was that you Cambridge physiologists don't discover anything. You just think really hard about what's right and then work away till you prove it. And I think that that could be maybe applied to George because he has been almost monomaniacally focused on the ventral medulla and how the neurons in this structure generate rhythmic respiratory output and what are the factors that control that. He's been part of numerous program project grants, including a SIDS program project grant with some investigators at Harvard and other locations, and more recently the Center Without Walls for SUDEP. With his engineering background, I think, and we'll maybe get a sense of this today, he's really been fearless about adopting new approaches and looking at things from new angles. So it's a real pleasure to have you, George.
Yeah, I really want to thank Chris and Rusty for inviting me, and also for organizing this CURE funding, which is really an honor to be able to be part of, and Melissa, thank you for your help too. And what Chris didn't mention was that he was actually a postdoc in my lab, and one of the best postdocs I've ever had, and fun to have in the lab too. So you're lucky to have received him here. And it's really a pleasure to be here to talk to you today. I'm not actually disappointed about not being an astronaut, and my wife is even less disappointed in that, because I fell in love with neuroscience, and that was really what I love to do. So I'm going to talk about SUDEP today, and this is a case of a patient who happened to be the son of one of the people on the board of directors for CURE, who's sponsoring this talk. And Chris Donalty was the son of Gene Donalty. He's 21 years old, went to college, and very good student, very good baseball player, and had well-controlled seizures. But when he went away to college, and this is quite typical, he had an increase in the number of his seizures, didn't really actually seek the help that he probably should have gotten at that point, and his girlfriend found him in bed, face down, and called the ambulance, and they were unable to resuscitate him. And this is a very typical story. And SUDEP is defined as the sudden unexpected death of a patient with epilepsy, and it's not due to trauma, drowning, or status epilepticus or other obvious causes. And an autopsy has to be normal, and most of these patients are found face down in bed after a sleep period. And some people call it sudden unexplained death in epilepsy, and they're both really correct in some ways, but in other ways they're not, and that's what I'm going to come back to at the end. one of the tragedies about SUDEP is that it's not really recognized, and it's really not clear to me why that is at this point, because it should be well recognized by doctors, and but many doctors don't know about it. It's not taught in most medical schools. Elizabeth Donner took a poll of Canadian pediatricians in Toronto, and most of them cared for children with epilepsy, but only 56% knew that children with epilepsy are at an increased risk of sudden unexplained death. And only a third of pediatricians caring for children with epilepsy even knew what SUDEP was. And this is probably very consistent with pediatric neurologists, pediatricians, and even neurologists in the United States as well. And this really shouldn't be the case. We should all know what this is. In fact, when I was a resident, I remember being told by my attendings that Yale was a good place for epilepsy. And I was told, you know, if a person has a seizure at home, they're usually fine, but if they happen to have a seizure in the cafeteria, then somebody will call a code on them, cafeteria at the hospital. Somebody will call a code on them, and they'll give them, you know, 20 of Valium, they'll intubate them, and then they'll get a pneumonia in the ICU, and they'll have all kinds of complications. So seizures are benign, but that actually now we realize that that's not the case. One of the problems is there's no biomarker to diagnose SUDEP. It's a diagnosis of exclusion. So as a result, it's a little hard to know what the exact numbers are for incidence, but these are widely accepted values for children. It's only 0.4 out of 1,000 for people with epilepsy. In the general population, it's 0.9 per 1,000. For patients that come to epilepsy clinics, it's 1.5 per 1,000, and those with refractory epilepsy requiring 2 or more drugs without good control, it's 6.2 per 1,000. So it gets a higher incidence the more severe the epilepsy is. And this is a distribution of SUDEP cases by age, and this is a little bit suspect for the reasons I just mentioned, in that people that are, the peak is about 30 to 40 years old, but people that are older often, if they have an autopsy and they find a little bit of atherosclerosis in the heart, they'll call it, you know, coronary artery disease as the cause of death, or you know, if they have, you know, some other minor problem, they'll ascribe the death to that rather than SUDEP. So we really don't know exactly what the incidence is in the older population. But and if you just look at the total number of patients with the condition, so there's about 3,000 per year in the United States, people who die of SUDEP. This is by Thurman, who was at the CDC. But he did a different analysis, which was to determine how many years of life a patient would lose if they had not died, or from dying rather. And if you do it that way, because Alzheimer's occurs in older people, so does Parkinson's disease, SUDEP becomes the second most common cause of death of neurological disease, second only to stroke in years of potential life lost. So it's a big problem. Everybody should be aware of it. And it's actually a big push by Cure as well. And it hits you when you meet the parents of people, of kids that have died, or people who have died of SUDEP, or our family members. And many of these people, I know their parents, and they each died at these ages. And many of the parents whose children or whose family members died were never heard of SUDEP until it happened to them. So I'm part of this Center for SUDEP Research. This came about largely because of Cure's efforts, including Gene Donalty, to convince the NIH to pay for this. It's a large grant with 14 sites, and Iowa is one of the 9 primary sites. And our goals are to determine why SUDEP occurs, try to find biomarkers to identify those at highest risk, and then determine ways to prevent SUDEP. So we're very interested in the mechanisms of how this occurs, and so there are some clues about what causes this death. One thing, the higher the frequency of seizures, the more likely you're going to die from SUDEP. If you have generalized seizures, you're more likely to die than if you have partial seizures, and I'll come back to that in a minute. It's more likely that it'll occur when you're in bed during a sleep period. It's not clear if it's during sleep or it's just being in bed or it's circadian. And patients are 70% at least of patients are in a face-down position in bed. And the genetics help, but there's some limitations. These are some genes that have been found in humans that have died of SUDEP, including SCN1A, which I'll come back to. This is a common cause of Dravet syndrome. There's a number of cardiac genes that are associated with it, including ones that cause long QT syndrome. And there's seizure-induced death in mice. And the first mouse model was the 5-HT2C receptor mouse. But one of the issues is that, especially with the cardiac genes, we don't know if it's assumed that because they're cardiac genes that cause long QT syndrome and an increased risk of sudden cardiac death, it's assumed that these deaths are due to sudden cardiac death. But these genes all are expressed in the brain as well as in the heart, and there's now a recognition that some of them lead to epilepsy. And even the other ones, it's really not clear if the reasons why they are more likely to cause SUDEP is because they're more likely to cause bad seizures, or if it's because with a given severity of seizure, it's more likely to cause death, maybe through brainstem mechanisms. So that's kind of the limitation of the genetic evidence. And what really comes down to, if you're going to die, there's really two ways you can die. Your heart can stop, or you can stop breathing. And after that, the other one follows shortly after that, or both happen at the same time. So there's been a lot of effort to try to figure out which one is primary, or are they both primary. But for the longest time, it was believed that SUDEP was just sudden cardiac death, just an arrhythmia that happened to occur in a person who had seizures, and maybe the seizure induced the arrhythmia. And so if that was the case, then what you would expect to see is pretty stereotypical. And this is an example from a sheep, but I'm sure that many of you have witnessed this in the ICU when you're taking care of a patient. If they have an arrhythmia or the heart stops for whatever reason, you'll see the same thing. And this is a case of a sheep where they caused ventricular fibrillation here. The blood pressure dropped close to 0. And as that happened, then frequency and tidal volume both increased over time, and then it slowly faded. Ventilation increased, and then this animal became apneic. And this temporary apnea then was punctuated by deep breaths called gasps, and those then, at this point in time, they defibrillated the sheep, and shortly afterwards the blood pressure came up and breathing restored. So this is very typical of what you'd expect. And I'll show you that that's not what happens in the cases of SUDEP that we know about. So unfortunately, there have been cases of SUDEP that occurred while patients were in an epilepsy monitoring unit, being videotaped, being monitored with EKG and EEG, and nurses in the room next door, and they had seizures that caused SUDEP, and everything was recorded, including the fact that the nurses didn't come into the room. And this is not the way to run an EMU, and I'll come back to that at the end. And these cases, at least the doctors reported them, and I actually know a number of places where they've had deaths in their EMUs that they didn't report because the lawyers wouldn't let them. And but these cases did, and that's actually the silver lining is that we now know something about what happens during SUDEP. So there were 16 cases of SUDEP that died in the EMUs. 11 of them had full video EEG and EKG monitoring at the time of death. And they couldn't get breathing because there was no direct measurement of breathing, but they watched the videotapes and saw what happened to the chest and the abdomen and counted breaths and noted when they occurred. So that's what we have, also looking at the EEG artifact. All of them that were monitored, 11 of them, occurred after a generalized tonic-clonic seizure, none of them during a partial seizure. And 13 out of 16 were in the prone position, face down. They didn't all start this way. They often started on their back, and then during the seizure they rolled over. I can't remember the numbers of patients that did that versus starting on their stomach. But so asking a person to sleep on their back may not be the way to solve this problem, because they may not stay there. So this is two examples that kind of show the different extremes of what happens with these SUDEP cases. And so the red line is the heart rate, and the blue line is breathing. And in this particular case, time zero is always when the seizure ended, and we really don't know what happened during the seizure. But after the seizure was over, this patient was breathing at a rate that was not that abnormal. But shortly, within a minute, the breathing decreased and stopped and didn't come back. About the same time, probably coterminous with that, coincident with that, the heart rate decreased at this point and then stopped and never came back. There's another example, which was more typical of the majority, and in this case, breathing after a couple minutes decreased and stopped, and then had periods of increased breathing returning, and then stopping, and then these two are the last two breaths that are gasps. But in each of these cases, it was not at all what I showed you with the sheet. So it wasn't that the heart stopped and then breathing increased for a period of time. And so this tells you that there's something going on with depression of breathing. In this case, the heart rate decreased initially, but then it came back up and it remained relatively normal for a long time, and it finally ended about 16 minutes afterwards. And we don't know what happened during the seizures, and there was no direct measurements of breathing. And remember that if you see movements of the chest or abdomen, it does not necessarily mean that there's air movement occurring. There could be obstruction, or there could be paradoxical breathing, or any variety of other reasons why air movement wouldn't occur. Yep?
So you mentioned these are, so all of the SUDEP deaths that were observed were following a generalized, a
Correct.
GTC. You also said at the beginning that these are not rated status. So
Correct.
how long are these GTCs?
As I recall, most of them were 3 to 4 minutes.
How many patients received the asthma or some rescue treatment?
None of these patients were, nobody observed it when it happened. It was later that they discovered that they had died. So nobody came in and tried to rescue them. There were some other cases in the paper that they actually did try to rescue them, and some of them they were successful, and others they weren't. So this is a figure from the paper where they showed the time of occurrence after the end of the seizure, time zero, for a variety of different things, including bradycardia, transient asystole, and so forth, transient apnea, and they show the different colors. And what I've done is taken the liberty to get rid of everything except for the terminal apnea and terminal asystole, so the last breath and the last heartbeat. And the blue is the time after terminal apnea, and the red is terminal asystole. This is one patient, another patient, another patient, 9 of the patients that they show here. And in each case, terminal apnea occurred before terminal asystole. And at the very least, what this tells you is that there has got to be depression of breathing that's occurring with this. It doesn't really tell you what the primary cause is, but it does tell you that there has to be depression of breathing to explain this. So I think we can conclude that SUDEP is not just sudden cardiac death in a patient with epilepsy, and the primary defect has to be in the CNS to explain this constellation of findings, and that it includes respiratory dysfunction. So kind of my focus has been, because I was interested in the control of breathing before, just the basic mechanisms that I wanted to understand what happens to breathing after a seizure to explain this. So it's been known for a few years, 1899, Eulerian-Jackson, that seizures can cause central apnea. And Lena Nashif in Britain showed that it can be severe after seizures. And Lisa Bateman here in the US showed that it can be very frequent. So she found that 33% of seizures cause oxygen saturation to drop below 90%, and 3.6% cause it to drop below 70%. And interestingly, even though death always occurs after generalized seizures, it was just as likely that apnea would occur after a partial seizure as it would after a generalized seizure. And we'll come back to why that might be the case later. This is an example from one of Lisa's papers. And this is the onset of a seizure and the end of a seizure. And you can see the oxygen saturation rapidly drops down to 30% and then recovers afterwards. And when we started doing this in our unit, the second patient that we monitored had a very benign seizure, like this one actually. It was also benign, where the patient just picked at her shirt and smacked her lips, and that was it. That was nothing more than that for 3 minutes, and her O2 saturation dropped to 20%. And that immediately made our nurses realize that this is important, because it was not hard to sell that at all when they realized how severe this can be in a patient who it doesn't even look like an obvious abnormality. And nobody notices when a person doesn't breathe. If a person's short of breath, taking really deep breaths, they're dyspneic, it's hard to avoid that, hard to miss that. But if a person stops breathing, a lot of people don't even notice. It's not obvious unless you're looking for it. So this was happening all the time, and people didn't actually know it. So we were interested in understanding the mechanisms of this, and so we wanted to turn to animal models. And I have a talented biomedical engineering Ph.D. student in my lab who built this system for epilepsy monitoring unit from mice. And it includes a chamber that holds the mice, and they can be there for months. You can eat in there and drink and just continuously monitor them and measure the breathing. As the animal takes a breath, the air in its lungs expands because it heats up and it humidifies, and both of those things cause expansion of gas. And you can measure that with a pressure transducer attached to the chamber. And we also measured with a head mount EEG, two EEG leads, EMG and EKG, and we took a video of this 24 hours a day and measured room temperature and humidity in the chamber to allow us to calculate the volume of air taken into the lungs through a series of equations, and also body temperature and movement. And this is the system as a whole. And this is an example of the software that she wrote to allow EEG, EMG, breathing. Plethysmography is breathing, and that's animal taking the breath each time. It's normal breathing, and measure the EKG and video. And Carl Feingold has done a lot of work on DBA mice, DBA1 and DBA2 mice, and has shown that these mice die after audiogenic seizures, and he has seen that it was a result of respiratory arrest, and he can save these mice by putting them on a ventilator quickly, doing basically mouth to snout resuscitation, and able to get them back to survive. And so we wanted to record this at the time that it happened, so we did this in our system. And these are the raw traces, and down below are the traces that have been expanded at each of these times. And what you can see is that before the seizure occurs, at this point in time, and this is the audiogenic stimulus, and then the seizure occurred here. Before the seizure, EKG is normal, plethysmography is normal, but 5 seconds afterwards, breathing had completely stopped and it never came back. And the EKG had begun to slow down already after 5 seconds, and then continually decreased. And you can see this is the average from, I forget if it's 8 or 9 animals, and breathing consistently stopped completely and did not come back, whereas the heart rate rapidly decreased, but then kept beating for a period of, in this case, 6 minutes. We actually don't really know exactly what happens during the seizure. We don't know if the animal stops breathing before this or before this period of time here, because there's a lot of artifact that's occurring during the seizure. But we recorded with a different system. In some cases, they stop breathing at the beginning of the seizure, and sometimes they stop breathing at the end of the seizure. But in each case, there's no breathing at the end.
This happens to every mouse that has this particular seizure disorder?
So this is a DBA1 that have audiogenic seizures. You need to prime them when they're young and induce the seizures. And the first ones that are induced, sometimes they don't get induced a seizure at all, and then they start having seizures, but they don't always cause respiratory arrest. Once you've got them primed, then as they get older, then you can do it. And about 90% of the time, when they have a seizure, they die from respiratory arrest, but not 100%. So, but in most cases. So we were interested in studying audiogenic seizures. I'm not really aware of anything that correlates with that in a human. There's musicogenic seizures, but that's not really the same. But this is a loud bell that induces it. So we wanted to study something that was more consistent with what occurs in humans. So we went to the Dravet syndrome mouse, which Dravet syndrome was described by Charlotte Dravet in 1978. It's childhood severe encephalopathy, epileptic encephalopathy that occurs often at 6 months of age, that they have prolonged generalized febrile seizures and then evolve into a number of other seizure types that are refractory to treatment with multiple medications. And it's really a syndrome because there's a lot of different causes, but about somewhere between 75 and 90% of cases are due to mutations of the sodium channel SCN1A, also known as NAV1.1, and about 4 to 12% of these children die from SUDEP. SCN1A is a voltage-gated sodium channel, and it's called a superculprit epilepsy gene. There's about 900 mutations that cause a variety of different epilepsy syndromes, but there's a variety of them that cause Dravet syndrome. And there's 2 mouse models that I know of. One used here by Bill Catterall and Franck Calumet is the SCN1A knockout mouse, and we're using the R1407X mutation, which they're probably slightly different in their manifestations, but they both are found basically in Dravet. The knockout, there's a lot of mutations that cause basically a deletion of the gene, and this has been found in, I believe, 3 patients that had this in humans. So the advantage is that it gives us a human homologue of a seizure disorder that we can study and correlate with what happens in humans. It's been shown that tonic seizures are followed by death, and death is preceded by progressive bradycardia, followed by asystole by Franck, but it's not known yet what happens to breathing. So we were interested because we're interested in breathing, we wanted to look at that. And what we did initially was we just hooked up a lot of web cameras, which are cheap, and monitored mouse cages, and then waited until animals died. And we could tell if they had a seizure from looking at the video, and we correlated that in other cases with recordings, and it's pretty obvious when they have a seizure with tonic extension at the end, and then die, and about half of the mice died within the first 2 months of being in the cages. Interestingly, mice were more likely to die in the dark phase. Which, first of all, the dark phase is supposed to be their active phase for mice. And second of all, they don't really have beds, and so they're not going to be dying face down in bed. So we don't really know why that is. It may be circadian influences, or they actually do. Mice sleep during the night, and they're active during the day. So it's not an all or none thing when they sleep. They don't always sleep all night, or I'm sorry, they don't always sleep all day and are awake all night. So actually, we're trying to go back and see if we can find clues to whether or not they were dying from what looked like sleep or not, but we're going to have to do recordings to do that. And even more interesting is that if you look at the time of seizures that were not fatal in these same mice that died, they actually had a number of seizures during the daytime, and they had more at the time they had the peak death, but they had fewer seizures in the morning hours when they were having quite a few deaths. So there has to be something more to it than just the time of day and the number of seizures. But we captured some spontaneous deaths with our monitoring system, which is important because there's really not very many other models that you can find. You can actually record a spontaneous death, which is really much more reflective of SUDEP than an induced seizure causing death. And so this is a naturalistic death, and these different times are shown down here. And this is normal breathing, and then during the seizure here, the animal had movements that looked like they were probably breathing, although there's another way we need to record it to be sure, not that these were movement artifact. EKG was going along fairly normally, but after the seizure was over at number 5 here, breathing basically stopped. These are just, the animal was moving a little bit at this point, but and breathing never came back after that. And the EKG slowly decreased after that point. And so this is that same animal plotting breathing and heart rate, and you can see that what happened is that at the end of the seizure, breathing stopped and it never came back. And the heart rate, again, decreased over time and finally stopped. Now, the advantage of these mice is you can also induce seizures when you want them to on command by heating them up with a heat lamp or with a hair dryer or something like that. And so you can induce the seizures when you're there watching and be able to manipulate, treat them, or do something to them. And so we did that, and we found basically the same result. And this is shown at these different times here. At the end of the seizure is the red, and breathing was normal before the seizure, and then right after the seizure was over, breathing stopped and never came back. And the heart rate was decreased at the time of the end of the seizure, but was still beating and slowly decreased after that. And so what we then did was just wanted to know how consistent this was in different mouse models. And we looked at 4 different mouse models, all with maximal electroshock, which also is not really a naturalistic seizure disorder, but maybe similar to electroconvulsive therapy, I suppose. But we did this in 4 strains of mice, including the Dravet syndrome, LMX1B mice, which I'll talk about in a minute, BBA1 mice, which are the audiogenic seizures, and C57 black 6 mice, but all inducing maximal electroshock. And in each case, they all stopped breathing at the end of the seizures, and it never came back, and the heart rate decreased with time. So that seems to be pretty consistent, that same pattern occurs with spontaneous and induced seizures in a variety of mouse models. So we're interested in knowing what happens in Dravet syndrome. There's been no published data on breathing after generalized seizures in Dravet syndrome patients. And so we wanted to do that, but we didn't have the ability to do it. They don't have them very often because they don't usually bring them in the hospital and take them off their medications. There's not really a lot of reason. These are not surgically treatable patients usually. And so we don't have belt recordings of their breathing at the time, so we were stuck with what we had, which was, again, the videotape recordings of breathing in patients that had had seizures. But we wanted to be able to extract more information from just watching the videos, because it's sometimes very difficult to be able to see their breathing. So we went to this technique called Eulerian video magnification. And this is an example. I'm going to show you a movie This is the raw data, or the original movie. And if you watch this for a few seconds, you won't be able to see this move at all. But this is a crane outside blowing in the wind. And then on the right, what they've done, this is a group at MIT, they've magnified the movement, and they do it over a frequency range of 0.2 to 0.25 hertz. Anything moving at that frequency, they exaggerate the movement and be able to bring it out better by magnifying it 100 times. You can do the same thing by looking at the color changes of the face, for example, and be able to see pulsations of blood in the face while this happens. Anybody gets on this website, you can see that. It's really pretty cool. So watch the left side for a second, and I'm going to tell you to watch the right. You're not going to see anything on the left side, but then I'll draw your attention to the right. You can see that it's not moving. Now look on the right side. Do it again. It's the exact same movie. It's just been processed to bring out these movements. It's much easier to see. Now what I'm going to do is I'm going to show you this baby, and I'm going to count 3 breaths. I want you to look on the left side, and you're not going to see much at all. I don't think you'll see anything. And then I'll draw your attention to the right side, and you'll watch 3 more breaths. So, okay. 1, 2, 3. Now look on the right side. 4, 5. There should have been a 6. I must have counted. But you got the point, right? So you can pull out these breathing that you couldn't see otherwise. So what we did then was this, Yujun Kim, my talented biomedical engineering student, did this for the videotapes that we had. You don't need to watch the left side. You can actually see movements in this case, but we magnified it 3 times in this case to be able to pull out the movements better. So just watch the right side and watch the belly button. Oops. This is after a seizure. I didn't get that right yesterday when I talked. This is after a seizure, and you can see that the breathing is occurring, but it's like the belly button goes up and bounces 2 or 3 times. I call this respiratory bigeminy or respiratory trigeminy. And it's an abnormal respiratory rhythm problem due to the generator in the brainstem not producing a nice activity that's normal sine wave-like activity. And I'll show you this in a different way. What she did was she drew this vertical line, and she plotted the color at each point, at each pixel in that vertical line, in the y-axis of this image here, and the x-axis was time. This happens to be the belly button right here, and this is the wall and stuff. And so what you're going to see, or what you see is that over time, this is what's happening to the belly button. And you can see there's like a double peak there, and I'm going to show that a little bit better here by expanding that portion, showing it here. This is while the seizure was occurring. It's pretty exaggerated, but the child was having these myoclonic jerks, and I wasn't really confident that these movements were a result of just movements from the jerks. But at this point in time, the seizure ended. There was a respiratory pause, and then the child began to breathe again. And you can see that there's a double peak. This is continuous trace, double peak, weird peak, double peak, maybe triple peak, and so on. So this is really, and then what happened is this again is continuous, and now breathing has returned to normal, like a sine wave almost. That is normal breathing. So this is an abnormality of respiratory rhythm generation. Now this is another child, and it's actually a little harder to see this, and actually she's magnified it 10 times, and it's easier to see, but I didn't put that one in here. But it's paradoxical breathing, but it's like super paradoxical breathing. So it's like everything's kind of out of synchronization. So it's very, very abnormal. And this has to occur from the rhythm generator in the medulla. And this is after a seizure. In a short period of time, she returned back to normal breathing Before the seizure, she was breathing normal. Like 20 seconds later, she was breathing normal. But right after the seizure, it was very abnormal. So there's definitely peri-ictal breathing abnormalities. And you'd say, well, they're breathing afterwards, right? But it's not normal breathing, and that may make them susceptible to death. And sometimes we would see apnea. Sometimes we see this ataxia, or bigeminy or trigeminy, paradoxical breathing. Sometimes we'd see airway obstruction, or we'd hear stridor, and that could occur with these other things. And we had one patient that was an 8-year-old girl that had 3 seizures in a row, and by the time of the last seizure, her transcutaneous CO2 had gone from, I believe, 44 to 70, and then after about an hour, it came down to 55, and it stayed there for 3 hours. So that tells you that there's something wrong with the system that's detecting the rise in CO2 in the brain, and it's not responding correctly to try to bring the breathing back to normal, or the CO2 back to normal. So if we know that respiratory rhythm generation occurs in the medulla, that's what Chris was talking to the residents about today. So how can these seizures in the forebrain affect breathing? And I worked with Brian DeLoe, who's one of our neurosurgeons, who happened to be recording from a patient who had frontal lobe seizures and did a pretty extensive subdural grid and depth electrodes in both amygdala and both hippocampi, and then happened to record 9 seizures. 4 of them spread slowly to the left amygdala. And when they hit the left amygdala, in this case right here, that was coincident with the occurrence of apnea. And that's shown here, it's normal breathing, and that's apnea. I think maybe 2 of them never went to the amygdala, and or 2 of them actually went to the amygdala so fast that it was hard to know what the timing relationship was, and the others never made it to the amygdala. So then, it was really the electrode that it coincided with was in the basolateral amygdala. So he stimulated that electrode and was able to reproduce this effect, and he went to 47 seconds because the longest the patient stopped breathing on their own was 48 seconds during the seizure. So he thought that would be safe, stimulated for 47 seconds and caused apnea, but didn't do that when he stimulated adjacent electrodes that weren't in the basolateral amygdala. And interestingly, what happened when this occurred, the patient was wide awake and alert. This was not during a seizure. The patient was wide awake and alert doing a Sudoku puzzle. Didn't make any mistakes, didn't stop working. And when it was over, they said, did you notice anything funny? And he said, no. And they said, did you feel short of breath? And he said, no. I said, were you breathing normally? Yes. Did you stop breathing? No. He was completely unaware that he had stopped breathing for 47 seconds. Of course, when he had a seizure, he was unconscious, so he didn't know that. We asked him to hold his breath for an equivalent amount of time. He was unable to hold his breath for 20 seconds without getting extremely short of breath. With multiple tries, he finally got to be able to hold for 60 seconds.
So his saturation about?
Yeah, so this is his O2 saturation. It dropped to 88%. This is during the seizure. I didn't show it, but it dropped to about 89%. When this was stimulated, he stopped breathing, dropped his O2 sat, and actually dropped it more than he did it when he voluntarily held his breath. And actually, when he did his breath hold for 20 seconds, he was incredibly short of breath, and it hadn't even started to come down yet. So it's unrelated to the O2 or the CO2, really. It's something else that's causing him to not feel that he's not breathing, and not recognize that he's not breathing. Obviously a problem if you've had a seizure and you're comatose with your face in a pillow, and you stop breathing and you don't know that you stopped breathing, and you don't wake up and turn your head and get your head out of the pillow. We then asked him to talk, and he was able to talk normally and had movement of air even when we were stimulating the amygdala. So it wasn't that we were paralyzing the respiratory muscles. We were somehow turning off his ability to generate automatic breathing, not voluntary breathing. So I became interested in this field primarily at the beginning because I was interested in serotonin neurons and their role in breathing, and it became clear from other people's data that these neurons may be involved in SUDEP, and we later found evidence that they might be the site of projections, or one of the site of projections from the amygdala. So the first evidence that serotonin is involved in SUDEP came from the first genetic mouse model, 5-HT2C receptor knockout mice that have fatal respiratory arrest after seizures, spontaneous seizures. And Carl Fangold, again, using these DBA1 and DBA2 mice, showed that if you treat animals with fluoxetine or Prozac, then you can reduce the respiratory arrest that normally occurs in a dose-dependent way, and so that you can eliminate that. That's an SSRI. And Lisa Bateman looked at patients who came into the hospital for the EMU admissions on SSRIs and found that they had less oxygen desaturation than those that weren't on SSRIs. Of course, that wasn't a controlled randomized study, but certainly consistent with this idea. So why would serotonin do this? Serotonin is produced by a very small number of neurons, mostly in the raphe nuclei of the brainstem. And we've shown through a number of years of work that these neurons are stimulated by a rise in CO2, which causes a decrease in pH. And it doesn't take much of a change in pH. This is really a physiologically relevant change to cause about a tripling of firing rate of these neurons when they're in isolation. These neurons happen to be located right next to the basilar artery and its main penetrating branches in the medulla. This is a pyramidal tract on either side of the basilar artery. This is the midline, and these are serotonin neurons in the midline surrounding the basilar artery. This is an overlay between the two next to these large arteries, and you can imagine that if their job is to sense blood CO2, this is as close as you can get to the heart without leaving the brain, and be able to detect changes in blood CO2, which correlate very closely with the ventilation of the lungs. And so we worked with Zhufeng Chen, Evan Daenerys, and Randy Johnson, who made these mice, not for us, but we got them, which have LOX-P sites around a transcription factor LMX1B that's required for serotonin neuron development, and Cre recombinase is driven by the gene PET1, which is found in all serotonin neurons and only serotonin neurons, and as a result, these mice have no serotonin neurons, and they survive to adulthood in some cases, but about 30 to 35% die in the first few days of life, and I think that the reason is because this is a wild-type mouse breathing normally at the age of 4 days after birth. This is a knockout mouse with no serotonin neurons, and you can see that it basically doesn't breathe for long periods of time, vocalizes here and here, which moves air, which probably kept it alive. If we follow that same two mice, these both survived. At 12 days of age, the wild-type mouse was now breathing like this, and the knockout had actually completely recovered, and something had changed in the brain to compensate for the loss of serotonin neurons. But clearly, serotonin neurons play an important role in breathing. And so we looked at these mice as they got older, and we challenged them to an increase in CO2 levels of the air that they were breathing, up to 7%, which is a pretty good stimulus. And it caused an increase in breathing of whatever that is, 3 to 4-fold. And the knockout mice increased by about half as much. The response that's left over is from either peripheral chemoreceptors or other central chemoreceptors. There was no effect on hypoxia, however. So we concluded from a large body of work that serotonin neurons are important for stimulating breathing in response to hypercapnia. So they're central respiratory chemoreceptors for CO2. And we're doing other experiments to understand why they are. It turns out that in a collaboration with Hal Blumenfeld at Yale, that these neurons are inhibited during seizures. So Hal has a approach where he has rats, where he puts an electrode in the hippocampus and kindles seizures. And when he does that, he records from the hippocampus, induces a seizure here, records breathing here, and also records from neurons, multi-unit activity of neurons in the medullary raphe where serotonin neurons are located. You can see that during the seizure, this group of neurons shuts down and then increases its firing later, and that corresponds with a decrease in breathing. Rats don't stop breathing. They actually don't die of SUDEP. We weren't ever able to get them to die from SUDEP, but they do have an inhibition of breathing. You can see before this is their breathing, which is pretty normal, but during the seizure, they decrease their breathing frequency and amplitude, and then that slowly recovers over time. So it's tempting to believe that the shutting down of serotonin neurons is a result of descending input from the amygdala. We know there's GABA neurons that project to the brainstem, and that inhibition of serotonin neurons may lead to respiratory arrest, which can lead to apnea in a susceptible individual like a Dravet patient or a Dravet mouse. So I told you that there was more to the story than just breathing, and it turns out that serotonin neurons are found in two groups, one in the medulla, which projects to the respiratory and cardiovascular nuclei and affects cardiovascular output and respiratory output breathing, which may both be involved in the death that occurs after a seizure, but importantly, there's a rostral group that projects to the forebrain and causes arousal from sleep, and it causes the limbic system to be activated, which can cause dyspnea, and other places in the forebrain to affect other functions. And if you shut these down and cause breathing and cardiovascular control to be inhibited, and you simultaneously inhibit these and make patients so they don't wake up from sleep when they're in a coma after, not sleep, but from a coma with their face in a pillow after seizure, and they also don't feel dyspnea because there's not the drive to the limbic system, that would be a bad thing. So I wanted to test this, and for those of you who don't follow the field, serotonin neurons have long been thought to be involved in arousal and sleep, and in fact, L-tryptophan from eating turkey has long been thought to, and drinking milk is thought to cause you to feel sleepy. And so when I got into a hotel in Boston for a meeting, I found this at my bedside each night, and it contains GABA, which of course gets destroyed in the stomach. It contained melatonin, which was in homeopathic dose, and L-tryptophan, which was also in a homeopathic dose. And it turns out turkey makes you fall asleep because you usually have wine with it, and you have a huge meal with mashed potatoes and you know, like a huge meal, and then you talk to your family and you all get tired and fall asleep. And chicken actually has more L-tryptophan than turkey, and we, through a series of experiments, showed that that's not actually the case, and serotonin actually wakes you up and not puts you to sleep. And reasons for that are a little complicated, but you can still make money if you want to sell stuff like this, because people believe it. And so we looked at serotonin neurons in the midbrain, and they were also chemosensitive, and they were also next to blood vessels. And if we take a mouse and we expose it to an increase in CO2 levels, it causes them to wake up immediately. But if you do the same thing to a mouse that has no serotonin neurons, they could care less. They stay asleep, or they'll even go to sleep when they have acidosis, when they have a rise in CO2. So they lose the ability to do that without serotonin neurons. I'll skip that. One of my former postdocs, Gordon Buchanan, did this experiment that I wish I had thought of, which is that he recorded activity of a mouse to determine if they're awake or asleep, and then measured the latency to arousal when he either dialyzed solution through the dorsal raphe through a microdialysis catheter that was either just normal saline or saline with a pH that was around 7.2, I think. and 7.1 maybe. And when he did it with acidosis, it caused these mice to wake up much quicker than if he did it with normal solution, CSF. And he did that in the mice with that are littermates for the knockouts without serotonin neurons, but with normal serotonin neurons, they woke up as well. But if he did it in mice that had no serotonin neurons, then acidosis in the dorsal raphe did not have an effect on their arousal. So those neurons we think are very important for arousal from sleep or perhaps arousal from coma as well as dyspnea. So the model we put
Was it the same response in REM versus non-REM?
He didn't do that. He just waited till he fell asleep and then did it. And it was, I believe it was usually in, I think it was, I don't know, I think it was always in non-REM, but I don't think he really didn't look at that yet. So the way we put this together is that these neurons that are serotonergic in the medulla detect changes in CO2 and cause an increase in breathing. Those in the midbrain respond to CO2 and cause you to wake up, and that also actually increases your ventilation, or waking up itself, as well as waking up and turning your head out of a pillow. And the way we put this together for SUDEP is that if a person has a complex partial, has a generalized tonic-clonic seizure, then it spreads to the medulla. It can cause inhibition of the descending modulatory networks, including serotonergic neurons that cause apnea, and at the same time can cause inhibition of the ascending modulatory networks and cause coma and prevent coma from reversing to the CO2. And if these two things occur together and you're in the prone position, you might die. But if the coma doesn't occur because of this not getting activated, then apnea, you can recover from apnea, which can explain why a complex partial seizure would not kill you, whereas a generalized tonic-clonic seizure would, because you need the coma and the apnea. Skip that. So coming back to the title of my talk, is SUDEP really sudden and unexpected? It may actually be that this is a recurrent event that these patients have. Whenever they have a seizure, they may have an episode of apnea, and it's the final one that's bad enough that kills them. It shouldn't be considered unexpected. Everybody here should expect this to be something that could occur in any patient who has seizures, even with their first seizure. It's now well known that that can actually happen. And some cases may be explained because they may be found face down in a pillow, and we can call that postictal asphyxia, but it doesn't change the fact that it's the same pathophysiology as SUDEP, even if you can explain it, and the approach to those patients should be the same. So what we're trying to do is determine why breathing stops after seizures, and try to identify biomarkers for those at highest risk of SUDEP, and then identify ways to prevent apnea after the seizures, and find new approaches to prevent death when apnea occurs after seizures. And we've been doing some last experiments where we find some patients who have a response when you have them breathe CO2 in through this tube. You can cause them to increase their ventilation here, and there are people that have a big response to that and others that have a small response. Turns out there's this, for a very small number of patients, our preliminary data suggests that this response, when it's a large response, when the CO2 rises, when the response is large, the CO2 after a seizure does not rise very high, whereas if the response to CO2 is low, then the CO2 rises a lot after the seizure. So this is a potential biomarker to be able to use. It's much easier than an EMU admission. This is done in clinic to determine if these people have a high CO2 response. And then those patients could be treated more aggressively. So the goal really should be to have no seizures, for you to know that respiratory depression occurs after seizures. And I think really at this point in time, all EMUs should routinely measure breathing in their patients. That should just be standard. And it can be done as simply as just an O2 saturation monitor and just be able to know if CO2 drops or O2 drops. And I think all family members of patients with refractory epilepsy should learn CPR. My sister saved her husband's life 20 years ago by giving CPR. She learned it over the phone when she called 911, and they told her, "Do you know how to do CPR?" And she said no, and they said, "Well, you're going to learn how to do it," and they taught her. And that was 20 years ago, and he's got a completely normal guy and since then. So there shouldn't be a reason why we should feel squeamish about telling our patients to learn, our families of patients to learn CPR. It should just be something they should know how to do. Patients want to know, by the way, that their patients' families want to know that the patients are at risk of this. They don't want to have us hide it from them. That's overwhelmingly the case. Oh, and people should avoid alcohol, narcotics, and benzos because they can depress breathing. So these are the people that did all this work, and I think I should stop there. This is also people from my lab and the funding that was provided to do this work. So thank you very much. Sorry I went over a little. I'm happy to take questions.
So there's, at least for other types of neurologic injuries like stroke, there's some suggestion that one side of the brain is more likely to cause autonomic side effects like non-ischemic troponin leaks or decreased cardiac contractility, and those seem to be more common on the non-dominant hemisphere. In the MORTEMUS study, was there any predilection for lateral?
No, and when Lisa Bateman has looked at this, what she found was it was most likely to have apnea when there was bilateral spread, and there wasn't a laterality to it. We found that actually stimulating the left or the right amygdala would cause apnea equally well, and we've actually found patients who had unilateral spread, or not unilateral spread, but unilateral seizures that had this. So I think the evidence doesn't really point to that yet.
What's the occurrence of SUDEP in patients with acquired epilepsy as opposed to genetically?
So it really doesn't differ if they have generalized seizures and they are and they're refractory. The evidence indicates that they are equally likely to have seizures. But I have to say that the people haven't really really investigated that, I think, deeply enough to know whether or not there might be some types of mutations that would make it so that your brainstem would be more likely to have respiratory arrest during the seizure. So some of the long QT syndrome genes are actually expressed. KCNQ2, for example, is expressed in respiratory nuclei. If there's a mutation in those, then that could certainly make the breathing rhythm more susceptible to inhibition. And it's possible that's what's happening with Dravet people and mice. So, Nick.
First of all, great talk. Really wonderful mixture of clinical and basic science. I was struck by those patient records of the people in EMUs who had completed SUDEPs. That it wasn't the respiratory change wasn't really like a step function, like 100% to zero. It often kind of dwindled over many seconds to minutes. Do you have any insight as to why that would be kind of a progressive?
So one of the things we don't know is what happened during the seizure, and if you take a person and you ask them to take a deep breath and then hold their breath, the O2 saturation takes a long time to drop. If you take a person and ask them to blow all the air out of their lungs and then hold their breath, it drops much quicker. In the mice, they tend to have tonic seizures where their whole body's contracting, and my guess is that they've blown all the air out of their lungs, and it's possible that in some cases that happens with humans during seizures. But I think that, so it may be that at the end of the seizure, the O2 and CO2 in the blood's already abnormal, and then what we're watching afterwards may be a response to that, or it may be that there's ineffective breathing at that point. Or it may be that there's something else going on initially, and that the depression of breathing may take a little while to occur, because this whole thing is maybe slow to respond because of second messenger pathways or whatever. I really don't know, but I think that is a very consistent response and very different than the mice. Remember that the rats, and we've tried Sprague-Dawley and one other strain, and they don't stop breathing at all. So it may be the individual predilection for either complete apnea versus no change in breathing versus a change in breathing that's intermediate may differ from individual to individual. So, but the mice are, inbred, so they tend to have a uniform response.
I can tell you the rats will have SUDEP. That happens to our guys all the time.
What strain are you using? Because we want it.
Using sprays.
Oh, really? Well, we were using maximal electroshock. What do you?
Well, these are like pilocarpine
Okay.
used epilepsy, so they're having 1 to 4 GTCs a day.
All right. Well, we've not done that, and I think maximal electroshock may be a different kind of seizure, and Hal used hippocampal kindling, and that may be a different seizure. So we should try that. We'd like that because rats are much better for some things.
So you're really interested in monitoring of the umbilical monitoring, showing this respiratory audiogenic. Is there an electrographic correlate with that? And the second question then, if there is, or I guess even if there isn't, in animal models, can you directly measure the outflow, electrographic outflow from the fluids?
Yeah.
Basically, to try and get back and get at what is that? Is it a respiratory thing, or is it really an electrographic?
So it has to be a change in the innervation or the drive to the diaphragm or the abdominal and thoracic respiratory muscles. And so if we were to record an EMG, there should be a correlate to that, and it has to come from the brain. Now these patients are all. It's very unusual for Dravet patients to be brought in and taken off their medication and monitored like this. So these were over a long period. Doug Nordley actually should have given credit for this. And Linda Lau made these recordings over a long period of time. And so I don't know that we're going to have the opportunity to do that. We can use belts easier than we can use EMG, muscle EMG of the diaphragm to do that. But and in mice, we don't see that same kind of thing. It's really abnormal respiratory rhythm generation. But that has to be, to get that kind of rhythm, it has to be driven by the control of the airway, of the muscles to the lungs, just the same as paradoxical breathing. Everybody knows about that, and it happens when people get fatigued. But that's a loss of the coordination of the breathing that occurs centrally.
So, with the approximately 30% of patients who are resistant to current treatments, it seems like it'd be easy to identify patients who might be at higher risk for SUDEP. So, what would be the barriers to just prescribing like a CPAP machine to these patients who aren't having their seizures while controlling potentially would be at risk for SUDEP?
Well, I think there shouldn't be a barrier. I think that it's taking time for people to come to agreement about what the mechanisms are of breathing, and if you accept that it's a respiratory problem, then that would make it an obvious thing. But I don't think everybody accepts that it's a respiratory problem, and so I think until that happens, then treatment's going to be, there's going to be other thoughts, and I think it may turn out to be that maybe a phrenic nerve pacer would be, better than a CPAP machine. You really want to make sure that somebody, doesn't stop breathing. The other alternative is just O2 sat monitoring. I know there was a woman who was a nurse at our hospital who had as a child febrile seizure that caused her to stop breathing, and she was admitted to the hospital, recovered, and now she's like the head nurse in one of our units. And she had a baby boy that was 3 years old who had 2 spells where he stopped breathing after a febrile seizure, brought him to the hospital. They worked him up, did everything with him, and then took him home, and that night he died in bed. It looked like he'd had a seizure. And so then she has a child that's 8 months old. And this is just like it was in April that she lost her other child. She has an 8-month-old child who just had a febrile seizure, and it looks like it stopped breathing afterwards, and so she's at wit's end. And she's bought an O2 sat monitor, and I have to tell her that, I didn't tell her because it's not my patient, but I'd have to tell her she's making the right choice. I don't have to say anything because she's doing it, but she's got the child in her room, O2 sat monitoring, because I think it's probably once they get through that period when they're not having febrile seizures, then this may go away. They don't have epilepsy. But that's the point that I think is important, that even your first seizure can kill you, and you think of febrile seizures as benign, but if it's combined with the fact that your respiratory network is somehow unstable, it only takes one generalized seizure of any kind, I think. It could be a provoked seizure, it could be epilepsy, or it could be your first seizure in a person who's going to get epileptic. So, yep.
That was an elegant presentation.
Thank you.
And I would not disagree with one iota of it, but I would ask you to put into perspective the observation that I and presumably other epileptologists have made in a monitoring unit where we would see somebody have a run of focal temporal spiking out of keeping with what had happened in previous hours, which would have had to have been considered an electrographic seizure, followed by cardiac arrest, immediately followed by cardiac arrest. I've seen this a number of times, and it was not something that lasted for 3 or 4 seconds. The heart had stopped until we went and tried to do something about it. I would think that in at least some cases, this was a precursor to SUDEP, or a cause for SUDEP. My question really is this a rarity, or is this just not something that has been investigated with the intensity of investigating the respiratory aspect of this?
No, I'd actually say a couple things to that. One is that my field is to study breathing, and I am tried to introduce to the field of SUDEP that respiratory abnormalities might be involved, whereas a lot of the field of SUDEP has thought that it's cardiac only. So I actually tried to throw in a few comments that I think that cardiac undoubtedly is involved, and I think it's a heterogeneous syndrome, and I think there's some cases that it's all cardiac, and other cases that it's mostly respiratory, and some that it's in between. And I don't know that anybody knows what the ratio is. The cases that were monitored in the unit, first of all, they're all temporal lobe epilepsy, taken off medication in a unit. It's a very select group of people, but all of those cases that were monitored were not primary cardiac, but it's very likely that does occur. There haven't been any reported cases of pure cardiac arrhythmia that occurs after a seizure, but there's been so few cases of any kind that have been monitored at the time of death that we can't tell. So I'm not disagreeing with you at all. I think that it's very possible that could be a large percentage, or it's certainly a percentage, and we just don't know what that percentage is. So.
Thanks for a great talk, George.